Hello, it is a pleasure to address you today. In this first short webinar, I will briefly review the persistent patient safety threat of postoperative residual neuromuscular block. In terms of disclosure, I will not discuss off-label use. I have intellectual property that I have assigned to Mayo Clinic. I have indirect funding from Merck with funding assigned to Mayo Clinic. I am a shareholder, member of the board of directors, and chief medical officer in Senzime. And I am an unpaid member of the scientific advisory boards of two international companies. In this brief webinar, I would like to cover the definition of residual neuromuscular block, present data on clinicians' awareness of this problem, and then give you some recent data on the incidence of the complication here in the United States and internationally. I will not go through all the details of the history of the development in the threshold of adequate recovery, but I would like to point out that over the decades, the threshold has changed. While the threshold of recovery was a train of 4 ratio of 0.7, the currently accepted threshold is a TOF ratio greater than 0.9. Importantly, recent work has shown that even when the train of 4 ratio has returned to its baseline, a train of 4 of 1, the patient's vital capacity is still depressed, and the ventilatory response to hypoxia is diminished, placing these patients at risk. While I'm sure that most of the audience is aware of the threat to patient safety posed by residual weakness, it is interesting to note that only a decade ago, 2/3 of American and half of European anesthesiologists believed the incidence of residual weakness was less than 1%. I'm confident, unfortunately, that a current survey, if performed today, might not show the improvement we would like. The data on incidence of postoperative residual block dates back to 1979, when the famous neuromuscular monitoring advocate, the Danish professor Jørgen Viby Mogensen, first reported that 42% of postoperative patients had a train of 4 ratio below 0.7, and almost a quarter of patients had a train of 4 ratio less than 0.6. It appears, unfortunately, that we have not made significant progress in the last 41 years. For instance, a major Canadian study published in 2015 that involved 10 major centers throughout Canada reported that despite the use of neostigmine as antagonist of neuromuscular block, in 3/4 of the patients, the incidence of residual weakness at the time of tracheal extubation was 63%. When tested later, once the patient had been transferred to the recovery area, more than half of patients still had residual weakness. Not to be outdone, a similar prospective multi-center study was performed in China, which enrolled almost 1,600 patients a year later. Similar to the practice in Canada, 3/4 of the enrolled patients had received neostigmine reversal, yet the incidence of residual block at the time of extubation was 58%. Surprisingly, the authors also note that the incidence of significant weakness, a train of 4 ratio below 0.6, was 23%. This measurement was performed, as the authors described, immediately prior to tracheal extubation, which really begs the obvious question of why the decision to extubate the trachea was made in the first place. Last year, the American RECITE study was published, which again reported identical findings to the Canadian RECITE study. 2/3 of postoperative patients had residual weakness despite neostigmine reversal. Finally, this year, a meta-analysis of all randomized controlled trials has reported that the incidence of residual block 60 minutes, that's 1 hour, after administration of neostigmine was 19% when antagonizing moderate block. This incidence, again, 1 hour after reversal, was an astonishing 39% when antagonizing D-block. Even when using sugammadex, the incidence was low, but unfortunately was not zero. I also wanted to briefly discuss the problem of residual weakness in pediatrics because they are a vulnerable group and because many of us who do not practice pediatric anesthesia may think that kids are immune to this complication. In fact, the incidence of residual block in pediatrics reported last year was similar to that in adult patients, almost 50%. It is clear that some of the same changes in our routine pediatric practice are needed. I would like to end this review by attempting to place the problem of residual weakness in some sort of perspective. Now, I'm in no way suggesting that residual block and malignant hypothermia result in similar outcomes. They clearly do not. But it would be helpful, I think, if we compared the resources we spend on the two. We know that conservatively, more than 110,000 American patients and more than 500,000 worldwide have a critical respiratory event associated with residual block. These critical events are defined as pneumonia, aspiration, need for reintubation and mechanical ventilation, significant desaturation, etc. Yet, many of us continue to believe that neuromuscular monitoring is superfluous. So I ask a rhetorical question. Would these same clinicians opt to save $6 million a year for expired dantrolene and not have a malignant hypothermia cart ready? I know that I personally would not be. Thank you very much for your attention. I have listed here on page 1 just some of the references that I used in this brief presentation. There are many other references available in their bibliographies. Page 2, as you see here, contains more references.